We've absolutely all been there, right? You wake up with that inevitable, frustrating scratch in the back of your throat, and you just know exactly what's coming next. It disrupts work, it ruins weekend plans, and it literally fills up waiting rooms across the globe. Well, welcome everyone. I am so thrilled to have you here for this explainer. Today, we're going to unpack the high-yield, evidence-based reality of the common cold. It's an illness we all think we know inside and out, but honestly, it is surprisingly complex. So here is our agenda for today. We'll start with the etiology of the common cold, move into clinical features and the timeline, then cover investigations and diagnosis, and wrap up with treatment and supportive care. Let's dive in. Okay, first things first, we really need to get our baseline definition straight. When we talk about a common cold, we are strictly talking about an acute, self-limited viral infection of the upper respiratory tract. And every single word in that definition actually matters. Acute just means it comes on quickly. Self-limited, and this is a huge concept we're going to come back to, means your body will naturally clear it on its own, completely without a cure. Viral tells us exactly the kind of pathogen we're up against. And upper respiratory, that means it primarily hangs out in the nose and throat rather than getting deep down into your lungs. You've got to keep this definition in the back of your mind because it literally dictates everything else we're about to discuss.
All right, Section 1, Etiology of the common cold. Let's look at what's actually causing this.
Get this. What is absolutely fascinating is that this single clinical presentation, the sniffles, the cough, the sore throat, it can actually be caused by an astonishing array of more than 200 different viruses. Over 200. And this is exactly why you can catch a cold multiple times in a single year. Your body might build up immunity to one specific virus, sure, but there are 199 others waiting right in line. It essentially leaves your immune system playing this never-ending game of whack-a-mole. Now, as you can see here, one heavy hitter really dominates the field. Rhinovirus is responsible for roughly 50% of all common cold cases. But take a look at that other half. It is a massive, diverse mix of culprits. We're talking coronaviruses, influenza, parainfluenza, adenovirus, RSV, and enterovirus. And the crazy thing is, they all trigger that exact same familiar cascade of cold symptoms. And regardless of which specific virus is to blame, transmission pretty much consistently happens through two main pathways. The first is direct contact. Think touching a contaminated doorknob, shaking someone's hand, and then rubbing your eyes or nose. The second is respiratory droplets, so inhaling those tiny invisible particles that get released when an infected person coughs, sneezes, or even just talks near you.
Moving right along to Section 2, Clinical Features and Timeline.
So, the life cycle of a cold actually has a highly predictable rhythm to it. It kicks off with a silent incubation period of 24 to 72 hours right after exposure. Then, symptoms start to develop gradually. It almost always begins with that classic scratchy sore throat. Over the next few days, this morphs into sneezing, rhinorrhea, which is just the fancy medical term for a runny nose, nasal congestion, and a cough. Finally, and this is the best part, we usually see full symptom resolution within 7 to 10 days. Now, here is a really crucial clinical pearl for you. If you're assessing an adult patient, a fever is usually completely absent. While kids might run a temperature with a standard cold, adults typically don't. So if an adult walks in with classic cold symptoms, but they also have a significant fever, that is your cue to immediately start thinking about other more severe differential diagnoses, like the flu or COVID-19. Furthermore, as the days tick by and the timeline progresses, patients are going to notice a very distinct change in their symptoms. Their nasal discharge will shift from being initially thin, clear, and watery to a much thicker or mucopurulent state later in the week. And I want to stress, this physical change is entirely normal. It's just the expected result of the body's immune cells going to work. Okay, I need you to focus closely on this next point because this is one of the biggest medical myths out there. Patients will often see that their mucus has turned thick, yellow, or green, and they instantly panic, assuming things have gotten worse. But the reality? That thick mucopurulent discharge does not, and I repeat, does absolutely not indicate a bacterial infection. It is quite literally just the natural progression of a viral cold. All right, Section 3, Investigations and Clinical Diagnosis. The absolute core takeaway for your clinical practice here is that diagnosis is primarily based on observation and taking a solid patient history. Routine laboratory tests, blood work, imaging, they are simply not required. If a patient comes in with a gradual onset of a sore throat followed by a runny nose and there's no fever, well, you've got your diagnosis right there in the exam room.
That being said, clinical restraint doesn't mean we just toss our testing tools out the window. We do reserve targeted viral testing for selected cases, specifically when we need to rule out specific threats. If the clinical picture looks a bit more severe, maybe they do have a high fever, extreme body aches, or a really severe isolated sore throat, that's exactly when we test for things like influenza, COVID-19, or streptococcal pharyngitis. The rule of thumb? We only test when the result will actively change our management plan.
Finally, let's wrap things up with Section 4, Treatment and Supportive Care. Think back for a second to our very first definition. We called this a self-limited viral infection. Because of that, management is strictly supportive care. We aren't curing the virus, we're just making the patient comfortable while their own immune system does the heavy lifting. This means using everyday tools like acetaminophen or NSAIDs for any minor aches, pain, or mild fever. We recommend nasal saline irrigation to clear out congestion safely, we emphasize getting adequate hydration and rest, and we can certainly use occasional cough suppressants, like dextromethorphan, if a persistent cough is really disrupting the patient's sleep. Please commit this next rule to memory. Because we are dealing with viruses, over 200 of them, remember, antibiotics are absolutely 100% not indicated. They will offer zero clinical benefit. Honestly, prescribing antibiotics for a viral cold doesn't just fail to help the patient, it actively harms them. It contributes to global antibiotic resistance and exposes them to completely unnecessary side effects. This is exactly why understanding the etiology is so incredibly crucial. And here is a massive red flag specifically for pediatric care. Always avoid over-the-counter cough and cold medications in children younger than 4 years old. These medications simply haven't been proven effective in young children, and they carry a very real risk of serious side effects. For the little ones, you really just want to stick to fluids, saline drops, and a good humidifier. So we've covered the etiology, the timeline, the proper way to diagnose, and the right way to manage care. But knowing that over 200 distinct, ever-mutating viruses cause these exact same frustrating symptoms, it leaves us with a pretty provocative question to end on. Will a single, universal cure for the common cold ever truly be possible? Or is this acutely annoying, self-limited infection just a permanent, unavoidable part of the human experience? Definitely something to think about the next time you feel that familiar scratch in the back of your throat. Thank you so much for joining me for this explainer. I really hope this brought some serious clarity to a very common topic. Keep learning, and I'll catch you on the next one.